Hello, my name is Katie Van Abel. I'm one of the head and neck cancer surgeons in Mayo Clinic, Rochester. I'm sorry we can't all be together for this meeting, but I'm excited to be able to share some information about device fundamentals and setup for the SP Da Vinci robot. Let's see here. I have nothing to disclose. I thought that it would be easiest to tackle this subject by sharing a little bit of experience and sharing some data that we've put together to sort of help define how best to use this new instrument. We started using the SP in 2018 and sort of looked back at a year's worth of our data. And by September 2019, we had 78 cases. We have 5 surgeons here using the robot with a varying number of cases based on their surgical practice. And I think this is nice because it sort of gives some insight into some of the difficulties had early on with the use of the SP and allowed us to try and figure out what things made surgeries easier, et cetera. So when we went back and looked at all of these cases, you can see that the patient demographics sort of meet what you would expect for a transoral robotic case series. The vast majority were squamous cell carcinoma, T1, T2, HPV positive base of tongue tumors were our most common. Notably, unlike what we've seen in our past series with the SI, we didn't have any larynx cases or hypopharynx cases. It's not clear whether that was based on surgeon comfort or the fact that these cases didn't come in. As with anything, things go in waves. And so we'll have to wait a little bit longer to see. The majority of the cases performed during this time period were torus tonsillectomy, base of tongue resection with concomitant neck, a few salvage cases, and you can see here that in a significant number of cases, we ligated vessels, placed clips transorally, and in all oncologic cases, we're able to achieve negative margins. So what things did we learn? How can we help understand how to best set up these cases, how to best use this equipment? Well, I think that being present in the operating room, being able to give you a hands-on explanation would be the best way to share how to set up one of these cases. And so I'll refer you to this surgical video atlas where my partner, Dr. Moore, sort of goes through that in detail. We use aquaplast mouth guards. We turn the patient 90 degrees from anesthesia with the left arm to anesthesia. And the right shoulder is towards the Da Vinci console, which is brought in straight in with the left foot sort of near that right shoulder. So the left foot of the console near the right shoulder. One of the questions that trainees frequently ask is, are we going to do nasal or oral intubation? What about tracheostomy? And then which retractor should we be using? There's a lot out there on the market. When we went back and looked at our data, we most frequently use a nasal intubation if we're doing base of tongue tumors. Our surgeons most frequently use a transoral intubation if we're doing a tonsil tumor. And it's really uncommon that we're doing tracheostomies for these cases. And in one of our patients, they had a pre-existing laryngectomy stoma, and so that was obviously used for their airway. As far as oral retractor, I think this is really going to depend on your comfort and also depend on what's available at your institution. Our surgeons are certainly more comfortable with the FK retractor. We did have the opportunity to trial the Med Robotic Flex retractor during this period of time. Ultimately, the surgeons in our group, and me included, sort of gravitated back towards the FK. We had one case done with the MacGyver and one I couldn't quite tell from the operative report. Most commonly, the straight blade for the FK is used for tonsil tumors and the curve for base of tongue. You can see down here at the bottom that I have the console time, which is calculated based on the time from procedure start or first tool installed to the first surgeon control, minus the procedure duration in minutes. And so this is something calculated by the robot and gave us a mean time of 82 minutes. And I'll note that this includes time waiting for the frozen section pathology to come back. So how did our surgeons feel about their access to the tumors? What sort of advice can we bring back to you? One of our surgeons said, I tend to open the mouth less for the tongue base than I did with the SI. This seems to create less crowding of the tissue and better visualization of the vallecula. So certainly some differences there. How about instrumentation? We have the option for a camera and 3 working arms. And some frequent questions are, what options do we have for those working arms? Like what equipment can we use? Is there enough room for that third arm? And which instruments did we find to be the most useful? So there are several options. I have pictures here of all the different options that Intuitive has available for the SP. We most frequently are using the Maryland bipolar, the spatula tip monopolar cautery, and the fenestrated bipolar. But certainly I've heard folks using the Cartier forceps over here in the right. One notable difference from the XI and the SI are that there is no available clip applier that's really useful for transoral surgery. The clip applier that is available is more useful for abdominal or thoracic surgery, as it's a much bigger clip. When we look back at our data, again, the vast majority of our surgeons use the 3 instruments I mentioned, and the majority of these really used 2 instruments, the Maryland bipolar powered and the monopolar cautery powered. So where do we put these instruments? Should we, how do we position the cannula? That can be a little bit tricky. And one of the things that we really need to talk about is how are we going to communicate with each other what we're doing with these instruments? And so one of the approaches that's been put forth is to refer to the cannula position closest to the mandibular teeth as the up position, and the position closest to the maxillary teeth, sorry, I'm saying this backwards. The position closest to the mandibular teeth as the down position, the position closest to the maxillary teeth as the up position. That is, the maxillary teeth are closest to the top of the head, so that would be up, mandibular closest to the feet, so that would be down. This, as you can see from my stumble there, can be a little bit confusing when you're sort of writing it down, but it makes sense to me surgically, and I think that this is something that we can understand communicating with each other. The right hand and the left hand makes sense because that's the surgeon's right and left hand. I think considerations for how to go about placing these instruments should be made based on the tumor location, size, how comfortable are you with 2 or 3 arms, how easy is it to open the mouth? Do you have room? Is there dentition? Can you get the mouth open wide enough? Are there mandibular tori or a really narrow mandibular arch width, which limits your ability to put your retractor in a place that gives you access to the tumor? All of those things are going to impact your decision of 2 versus 3 arms, whether you set the cannula up, off to the side, sort of so you're going cross court toward the tumor. If you're straight on, I think all those things will be important. When we surveyed our surgeons, the majority of us were using the camera in the down position. This allows you to cobra your camera into the palatal fossa, giving you space to bring your working arms up over the top of the camera so you can avoid skipping, like we'll talk about here in a moment. And then most frequently, people are putting the cautery powered in their right hand and the Maryland bipolar powered in their left hand. I like to use the fenestrated bipolar in my third arm, and I think that can be handy, but it certainly takes some getting used to and is not always a possible option for all cases. One of my partners says I operate with a Bovie ipsilateral to the tumor, and for tongue bases will flip halfway through the case. If I use the third arm, I probably wouldn't do this, but I haven't incorporated this much. And so I have heard of people sort of switching halfway through, so then they're not reaching across their camera with a potential for skipping, like we'll talk about. So I've mentioned this a couple of times. What is this skipping or jumping that we're talking about? This is when the arm, in this situation, I have the monopolar cautery in the right hand, the bipolar in the left hand, camera in the down position. And as I am starting to work up and over the camera, you can see that the arm can ride up along the camera. And then when it reaches its highest point, can skip. And I've seen it skip a good distance. Haven't fortunately had any injuries related to this, but it can be sort of disconcerting. And so some pearls to take away as far as logistics go for using this instrument. I think if you can back your camera up, try and get your elbows out. So having those elbows out is really important. You're working less on the wristed movement and more having your elbows out to get to your target area is helpful. And then if you start to see your instrument flex or your camera start to flex, know that that's happening. At the beginning, get up from the console, walk over to the head of the bed, look down at the instrument. So you start to get in your mind that 3D sort of understanding and feel of how your instruments with this new equipment are moving. Stop, readjust, sort of reposition your camera, reposition your arm so you can prevent that skipping. And then pay a little bit of attention to the warning colors that are at the bottom of the display screen. I will say that they're often warning you, so it's hard to interpret that very well, but it's something you can look at. Next, we'll talk about the camera. Where do you put that? How do you Cobra? This Cobra is sort of like a unique thing to the SP, and can be very helpful, but it also can be a little bit challenging to control at first. So you want to avoid placing your camera between your working arms, otherwise you're going to sort of block yourself. And you can consider moving your camera back to sort of make space. The other thing, like we talked about, is you can Cobra down into that palatal fossa. One of the tips one of the intuitive engineers gave me is if you clutch your right hand, flex your wrist all the way up to the console, unclutch, click into your camera control, and then extend your wrist down and drop it into Cobra. That can give you maximum Cobra. There's also a new feature on the SP that allows you to do an auto Cobra. I think that this can be, great. I haven't had a ton of experience with it yet, but one of the challenges I've found with it is I don't always have room to do a full Cobra. So I do need to sort of adjust that based on the patient's anatomy. Next, there is no ability to adjust manually the focus with the SP. It's a fixed focal length, and then it will allow you to optically zoom in. Initially, this seemed to be more of a challenge. I think it was just a matter of kind of getting used to it. I don't notice it as much anymore, but certainly, it was a concern early on. There's a navigator view you should be thinking about down in the bottom, and it's really a helpful thing to be able to reference during your operation. You have 3 options: the side view, the front view, and the top view. I personally really like this side view navigator because I can see where my camera is in relationship to that plane with the working arms and try and prevent me from creating contact there. So your goal really with this navigator view is to see the camera in relationship to those working arms, see the position of your working arm. Sometimes you'll lose a view of your arm, and you want to be able to kind of reference your navigator view to see what's going on with that, so you can back up and try and get it back into your view. And then the last thing is, if you're using that third arm and you sort of put it out of view, you can glance down at your navigator to make sure that your third arm is somewhere safe. Okay, next we're going to talk about what settings you should put the Da Vinci on. There's sort of some new power settings here. The energy settings range from 2 to 4 most commonly in our series. Unfortunately, I wasn't able to get any record of the cautery settings, so this is all subjective, questioning of the surgeons at our institution. Most commonly, people reported putting the power settings on 2 or 3. I would just recommend that you start similar to lasers, start low and work up. I have found that the cautery seems to react a little bit differently depending on the patient's tissue. So from one patient to the next, the power seems to just be a little bit different. So I start at 2 and then go from there. I had a few miscellaneous bits of pearls, I'd say. Sometimes bipolar, when you start bipolaring, will just automatically turn off before you think that your bipolar action should be complete. This was put in there as a safety measure, but I think that it's very reasonable and safe to turn that auto off feature off on the cautery box. This will allow you to bipolar until you think that the tissue is sufficiently bipolared. And then if you're using that third arm, when you toggle to the third arm, sometimes it won't activate. If you just gently open and close your fingers, that will allow you to click into that third arm in an active way. So in conclusion, I would say that comfort certainly improves with this device over time, just like any procedure. For folks who have a lot of experience with the SI or the XI, I would caution you that this isn't the same old car with a new paint job. This really is a new machine. And so for our surgeons that had a significant SI experience, it seemed to take about 10 to 20 cases before people were feeling a lot more comfortable. I think that the only way to get this experience is console time. Fortunately, there's a great simulator out now for the SP that really focuses on more trans corridor or trans oral surgery. It's certainly useful for other folks, but the initial simulations were for more abdominal or transthoracic, where there's bigger working space. But this really forces you to work down a corridor, and I think that it's really helpful. And then just patience. When we look back at our experience, one of the surgeons with less SP experience said, if I still had the SI, I would pick it every time. But when I looked to the surgeon with the most SP experience, that person said, if I still had the SI, I'd pick the SP every time. So, I think that this is something that takes some time to get used to. And when I asked what the best things were about the SP, I was told the flexibility, ability to see the tongue base with less mouth opening, which affords less pressure on the tongue and deeper cutting of tissue, and also the bipolar and the third arm. And this person really likes the energy settings. With that, I will conclude. I would love to refer you to headmirror.com, where we have some nice surgical videos. This one in particular uses the SP, and it was too long to incorporate into this talk, but really walks through the setup with some video of that device. And then I reviewed in a little bit more detail with more feedback from the surgeons than I reported in this talk in a publication that just came out in Head and Neck. So if you have any questions, please don't hesitate to contact me. You can email me at my address here below. And I look forward to seeing you all hopefully in person in the future.